Hi. As mentioned, I'm Andrew Jack, and I'm one of the complex spine and peripheral nerve surgeons here at the University of Alberta up in Edmonton. And I'm going to be talking today about hip and spine syndrome. And I have no conflicts to declare, and I'd just like to thank Dr. Hart and the other faculty for inviting me to talk at this great course here today. Some of the objectives that we'll be covering today then, we'll be discussing the epidemiology and classification of hip and spine syndrome patients, and probably more importantly, the impact of this treatment and the implications of it, as well as the approach in treating these patients when they do present to you. And so one of the most pertinent questions that comes up is obviously then for these patients, well, which do you treat first? If they have dual pathologies, do you treat the lumbar spine first, or do you then and then refer them on for an arthroplasty treatment, or do you treat the hip in the way of arthroplasty followed by the spine? And so going back a little bit into the history of this problem, it was initially described by O'Fierski and McNabb in the early 1980s. And the way they had defined it in their seminal paper was as a symptom complex that results from concurrent hip and spine pathology. And so as you can see then, it's a fairly broad definition that many different patients may fall under, and it really kind of centers around the patient presentation, their chief complaint, and their symptomatology. It's a fairly burdensome disease with upwards of 20% of arthroplasty patients also having degenerative lumbar disease, albeit a relatively smaller minority actually will have gone on or have had previous lumbar spine surgery. And so in that original paper that I mentioned, they classify patients as either simple, complex, secondary, or misdiagnosed. However, in parallel to what we've seen in the spine literature over the past 10 to 15 years, these patients there's been a shift in defining them more in terms of their radiographic parameters in the way of spinal pelvic parameters or the relationship between their spine and their hip. And so going back to that initial question that we had asked, there have been a couple of cohort studies looking at this, and specifically pain and health-related quality of life outcome measures. And this cohort study looked at spine-first patients, so patients who have had their lumbar spine treated and then went on to have a hip arthroplasty, compared to arthroplasty alone patients. And what they found was that the hip and spine patients complained of worsening or worse pain in the way of VAS scores, worse EQ5D scores, as well as satisfaction scores post-operatively. And subsequent to that study, they also then looked at hip-first patients who then went on to have their spine treated compared to arthroplasty patients alone. And again, maybe not surprisingly, these patients also complained of worse back pain scores, mobility, and return to usual function scores. And I say not maybe surprisingly, simply because you're kind of comparing almost two different categories of patients, one with potentially two different disease processes or the same disease process, but further along on the spectrum compared to the arthroplasty alone patients. And the outcomes for these patients aren't necessarily, or worse outcomes rather, aren't simply isolated to pain and health-related quality of life outcomes. They also report much higher rates of complications in the way of dislocations and thus revisions as well. And at least a part of that is probably due to the altered biomechanics and the relationship that exists for these patients between their spine and their hip. And so this is one of the first articles that kind of addressed this and looked at the interplay between the two joints back in 2005 by Buckland et al. And JBJS. And what they found was that by changing different spinal pelvic parameters, there's actually a change in the acetabular anteversion as well, which then obviously affects its placement during the arthroplasty. And close to that time as well, there's another article that came out in JBJS looking at trying to explain these different biomechanics, and they grouped patients kind of into four different categories. And you can see in the bottom right here, this is what they termed a patient who had a balanced spine, but was obviously rigid, having undergone a previous fusion. And what normally happens is when we go from a standing to sitting position, the spinal pelvic junction should normally retrovert and increase our pelvic tilt. But in this case, because they're fused and you can't see that retroversion, you can end up with anterior impingement and thus posterior dislocation. And thus, this patient might require or may benefit from a relatively more acetabular anteversion. And conversely, in the bottom right here, again, this was another category of patient that they looked at. And this is obviously someone, again, who's undergone a spine fusion, although albeit somewhat suboptimally being fused in what looks like somewhat of a flat back type deformity. And so they can't actually, when they go from a sitting to standing up position, normally lower dose, and their spinal pelvic junction can't antevert, which can then result in posterior impingement and anterior dislocation. So this person may then benefit from potentially a little bit less anteversion in their acetabular placement. And this kind of mimics, again, what you see then in the top left there, which would be more in keeping with a semi-rigid kind of adult spinal deformity-like patient. And so looking at the literature behind some of these problems then, these are a series of papers then that have looked at spine first patients compared to arthroplasty alone patients. And again, not surprisingly, uniformly amongst them, you see higher dislocation and revision rates for these hip and spine syndrome patients. And this is a figure taken from one of those papers that also reflects that. And on the other side of the spectrum, then, if you look at hip first patients who then go on to have their spine treated versus arthroplasty alone patients, again, much in keeping with what we previously mentioned in the last series of papers, again, they report higher dislocation rates and revision rates as well. And interestingly, this was a figure taken from one of those papers, and what they found was that there isn't actually a spike in perioperative dislocations that you might expect, but instead there seems to be a relatively constant increased rate of dislocation in the hip and spine syndrome patients. And there's actually only been a couple of different papers that have looked at comparing the two different cohorts that we're most interested in trying to answer that question as to which to do first. So these are papers then that compared hip first patients to spine first patients with contrasting results. So on the top, this was a retrospective study, or sorry, rather a prospective study done out of the UK. And what they found was that in their series, there actually wasn't an increased rate of complications when you compare hip versus spine first patients, although both did have higher complications than the arthroplasty alone group of patients. And again, that was the same for their revisions outcome, as well as they didn't find a difference with respect to changes in their patient-reported outcome measures. And I said previously, contrastly, the bottom article, this was a retrospective article looking at a large series of Medicare patients, and they did find a difference with respect to outcomes with hip first patients having a lower rate of dislocations and revisions as opposed to the spine first patients. And I think the underlying issue to a lot of these articles is that none of them really address and classify their cohorts of patients radiographically. And so I think what's going on is there probably is a mixing or missing patient subgroups, which is why then we end up with somewhat mixed results in a lot of them. And all of that is to say then that lumbar spondylotic disease is not necessarily the same thing as an adult spinal deformity. So, the outcomes for somebody in this case having a garden variety, maybe 1 or 2 level fusion is probably not going to be the same as somebody who has a large adult spinal deformity with a large pelvic tilt, for example, positive SVA, et cetera. And that's been reflected in some of the more recent articles. This was a meta-analysis done kind of highlighting the fact that none of these previous studies look at spinal pelvic parameters, but the ones that do here find that dislocators have a higher pelvic tilt and PILL mismatch, and thus in keeping with an adult spinal deformity, and are then potentially at risk for dislocation. And that's also reflected again in a more recent publication here from the group in New York, who then looked at all of their arthroplasty patients and found a difference statistically between them with respect to their radiographic parameters, and went on to classify these patients with respect to these parameters into 4 different categories. And not surprisingly, they find different compensatory mechanisms in dealing with these disease processes, and then further recommend, for these types of patients that they're probably best with a multidisciplinary approach. And this is really kind of a problem that needs to be studied prospectively with proper patient stratification. And so with respect to when these patients do present, I think that the overwhelming, or I shouldn't say overwhelming, but a lot of the literature does suggest that maybe a hip first approach is best. However, there is definitely a subgroup of patients, and that's what this article kind of highlights here, that do have an unbalanced spine, so more in keeping with an adult spinal deformity, where spinal realignment and fusing them in a fixed position, which then can guide acetabular cup positioning, is probably best to decrease these complications. And so I'll kind of leave it at that with the approach to patients then with this problem. I think it is important that we properly identify and classify them and do take a multidisciplinary approach to them. And for the majority, a hip first approach may be best, although those with an unbalanced or stiff deformity may be best served with their lumbar spine being treated first. And again, I don't think there's too many people who would also argue with the fact that if these patients do present with a potentially irreversible neurological deficit, that the spine is probably best being treated first. So thank you guys for inviting me to talk and paying attention. And if you guys have any questions, I'm more than happy to discuss them.
Thanks, Andrew. That was a great summary of, as I said, kind of an emerging area of discussion and recognition of potential problems from both directions. So, Dr. Askuyan, you're looking very thoughtful. Do you want to ask a question?
Yeah. So, Andrew, that was a great talk. So I have a question for you. Actually, this is a real life example. I have a patient that Jens and I did a deformity surgery on. And then she had 2 very bad hips. And the surgeon she had a deformity surgery like 5 years ago. Then she had a hip replacement on one side. And her balance is pretty good. I wish I could show you the x-rays. She had not that much. She had a pretty severe coronal deformity, which we corrected, and she's done fine. But she had 1 hip replaced, and it was done, just the standard approach. And then she keeps now displacing anteriorly. She's had 4 dislocations with her new hip. And the surgeon, we both know the orthopedic surgeon that did her hip replacement, and he wants to now operate on the other side because the other hip needs to get fixed. But she's just terrified of this happening on both sides. And now the left side is the problem. And the orthopedic surgeon said, you need to go back and have Chapman and Askuyan fix your spine. And she has a solid fusion now. So what do you think we should do?
And so I think you guys are taking exactly the right approach. I think with these complicated type of patients, a multidisciplinary approach is going to be best. Now, it sounds like she's already had a spinal fusion, and it was obviously adequately done, and she's well balanced and that sort of thing. And so she has what sounds like a balanced yet rigid type of spine. And I think that should ultimately guide the way in which her acetabulum is then placed with respect to her hip surgery. And it's difficult to say without knowing all of the details as to why she may be continuing to dislocate on the other side. But it could be that, one thing that has changed in the arthroplasty world is this idea that there's a safe acetabular zone for placement or cup positioning. I think it really has to be more patient dependent as to what they need. And it may be that she requires a little bit more radiographic workup with respect to dynamic films such as supine, sitting, and standing, AP and pelvic x-rays, as well as scoliotic views to be able to better define what is going to be a safe zone for her.
So do you think, so she went and got a second opinion, and the surgeon that saw her said that you need to have an anterior hip revision, and they need to change your cup size out before they proceed with the other hip. I don't know if any of the ortho guys can jump in, but I didn't. She came back to me and said, Dr. Sculian, what should I do? I don't know the right answer, but maybe you're right, Andrew. Maybe looking at the acetabulum and the current cup size she has, or changing the biomechanics of that hip might make a difference.
You're absolutely right, and there are different things that can be done technically or surgically to also try and decrease the incidence of dislocations post-operatively. You mentioned one. You can change the relationship of the femoral head to stem. You can use multi-component hardware, for example, a tripolar cup. Different approaches also, as you pointed out, tend to lead to different incidences of dislocation. The highest being traditionally a posterior approach, where then surgeons wouldn't repair the short external rotators and posterior capsule. There seems to be more of a trend to going now to a lateral or anterolateral approach, which is considered a little bit more MIS type approach, which leads to then less violation of the soft tissue around the arthroplasty positioning, and thus less dislocation.
I'd underline that last comment, and without disrespect to our general orthopedic colleagues, I think a conversation between the spine surgeon and the total joint surgeon preoperatively, whether the hip is done first or the spine is done first, is necessary. And in locating and helping a patient select a surgeon for their total joint, I think you want somebody who really focuses only on that discipline and is specialty trained in joint replacement, as opposed to somebody who maybe does a community practice with a smaller number, because I think all of us recognize that it's hard intraoperatively still to judge where that cup is going and how much anteversion is being placed. And surgeons that do this routinely have a much better eye for that, I think, than surgeons who do them less regularly, and also have access and knowledge to a whole host of sort of high-end specialty-specific alternatives in terms of the cup design and the, as you said, the femoral head or the femoral stem design. Yes, and so from our audience, we just had a comment regarding the potential use of EOS, and that's having full body X-rays preoperatively for patients who have peripheral joint problems as well as spine, I think is absolutely a benefit of that system as well. Ted,
I just wanted to ask. I wanted to ask a question to Dr. Jack. Have they looked at pelvic obliquity? Because that's a follow-up from the long X-rays that are probably necessary. I just wondered if the obliquity had ever been looked at.
So you touch on a very, very good point, and I think it speaks to the importance, as Dr. Hart was saying, in making sure that these patients are seeing someone who is very familiar with this specific problem, because these patients can be quite challenging. And as a part of their workup, it is important to then also try and sort out what the primary driver of their disease is. So, for example, as you're saying, somebody who has pelvic obliquity, that could be, for example, due to an adduction type contracture, which is then leading to a reactive type scoliosis, and then performing a hip first like approach may actually help correct their deformity. And alternatively, again, somebody who has a scoliotic like deformity may actually lead to altered pelvic tilt and obliquity, leading to uncovering then of their femoral head and an advanced degeneration of it. And so it is important that these people see a very specialized type of surgeon to be able to help better categorize them and decide on which type of treatment is going to be best for that individual patient.
Okay, that's a great session, great comments. Thanks again, Andrew, so much for that well-crafted talk.